Very welcome indeed to this, our video number 3 in the month-long bowel cancer awareness program that we've scheduled here at Cancer Care West. And as you know, I'm John. I'm the clinical psychologist based up in Letterkenny with Cancer Care West. But I'm very pleased indeed to introduce to you today Olivia Dunleavy. And Olivia is a colorectal clinical nurse specialist, and she's based in UCHG, that's the University Hospital in Galway. And she's very graciously, I say very graciously, given her time for a conversation today with us. It's not going to be over 15 minutes, but we hope to cover a few things in this conversation. And as I say, I'm very, very grateful for Olivia to kind of give us our time, and I hope that you all kind of get something from this. So I'm just going to ask a series of questions, and maybe we'll get into some bits of conversation about some of the fine points of that. I just to kick off, Olivia, what's your role? What's your role in supporting cancer patients?
So I suppose my main role is, well, my job title is colorectal CNS, so it covers cancer of the colon and of the rectum. So and I suppose my main role would be liaison and an advocate for the patient. So just to give an example, in my day-to-day activities as a clinical nurse specialist, if somebody presented to the hospital and was scoped, and if they did find something that was suspicious, I at that stage would go up and meet the patient and would explain the relevant pathway to the patient. I suppose, like a lot of people, bowel cancer isn't a popular cancer that people want to talk about, because our bathroom habits are very much personal. So I kind of would explain basically where the lesion or the growth is that they've found. I give them a diagram so they have written information going home, and then I kind of explain to them from this, where do we go from this? What's necessary to evaluate this more? I would go through like the practical points, like people often wonder how long does it take a biopsy to come back, so at least they have a date going home. Then I would explain to them then if we needed further imaging, like as in a CT scan or an MRI, and also I would take a general history of the patient so we have a baseline going forward. So at least I suppose their initial presentation is captured at the very, very start of it. I also would explain to the patient who they have subsequently been referred to, and I also would give in written documentation of this. I suppose I write down and hand out the exact pointers of where we're going with this. So at least, because everything can be kind of a blur, because it's such a shock when you come in for something and then you're subsequently diagnosed with something, everything, and then you hear cancer, everything goes out the window. So at least they go home with the written piece of paper, so they can then at their leisure then, kind of process things. I suppose the biggest thing is that they go home with my contact details. So I am the initial point of contact. I would explain to them then, usually what I do is I phone them the following day then to touch base with them, just see how they're doing. Like if it needs be, I'll ring them every single day until we've seen them formally in a clinic, or if it's thing, they'll phone me, and patients do ring because they're quite happy with the service, and they're quite comfortable with the service.
It sounds like, Olivia, that you're sort of there in from day one almost, isn't it? That you're sort of very, very early on in the whole proceededings, I think.
Yeah, and I suppose you're meeting these people at the most vulnerable. They're at their most vulnerable, so you're there to carry them along until until they're able to kind of gain control again, because it throws a person off when you do receive a cancer diagnosis.
I'm aware that people are in the background, just to viewers, but it's a busy office. This is kind of live from the sort of HSE, if you like. So
the hub,
absolutely. So this is as real as it kind of gets, I guess, in that sense. So I suppose one of the things in terms of communication with patients, what do you think is what do you think are the most sort of common questions you get from patients? What do you think they ask you the most about?
I suppose the biggest one is this treatable? That's the
Okay.
biggest question, regardless of what way things are, you know what I mean? And it's irrelevant of whether they're 30 years of age being diagnosed or 80 years of age. Is it treatable? So, you know, then you would go through, like explain to everyone that there's options, always options. So I suppose we would go through then. I suppose the big thing now is, and I'm over 20 years nursing, where the patient now is very much empowered. The patient has an awful lot of knowledge now, more than they ever had.
Mhm.
So like I feel that the more information you give a patient to break it down, because this is a total unknown journey that they're on. So at least if they understand where we're going, they can, you know what I mean, they just get a better acceptance of things. So I suppose like to go through their options. I suppose with say a cancer diagnosis of the rectum, and not all, this is very generalized, very broad, a lot of them would receive treatment up front. So then the patient would be concerned then thinking, okay, if I'm getting treatment up front, this must be a very bad tumor. It's not. It's just the way we've proven over time that there's overall better outcome for surgical, and also to minimize the risk of this coming back, to give the treatment up front. So again, to explain the rationale. Another questions then people would ask when we do give them, we give them a diagram of what the large bowel and the rectum looks like, and we show how much we remove, which is quite a lot of your bowel. But I suppose a big thing is for the patient then is, how will my bowel function? You're taking away this amount
Mhm.
of colon.
Mhm. Mhm.
Overall, what's my bowel function going to be like? So we would go through then what they can expect maybe for the first 3 months, 6 months, up until a year after surgery. So at least when they do go home from the hospital, they'll know that if the stool is quite loose, or if they're going a bit more frequently, that this is normal. Because I suppose another big fear would be like, oh, the tumor has come back. This is the way I presented initially. So just to kind of alleviate that, I suppose then patients, and we would discuss about having a stoma, which either is temporary or permanent, depending on the location of your tumor. And again, I utilize all the resources that I have here, and I engage the stoma care nurse, and her name is Mary Quigley, and she would meet the patient at the time when we meet them in clinic, again, just to give them information of, you know, what's involved and what isn't involved with it. So the more knowledge the patient has, the more empowered the patient is.
Excellent. So that's a very good point. That the more information somebody has, the more aware. And I love the idea of the diagram as well, because that, a picture paints a thousand words,
Yeah,
isn't it, really? So they have at least a visual,
exactly. And
they
they
have a
have it then
visual.
when they go home. Yeah, they can actually see, as opposed to you trying to describe it, they can
Yeah,
physically see what it looks like. So yeah, it
yeah,
does help.
yeah, absolutely. So, bearing on that information, what do you think is the best advice you give patients along the way, particularly during, I suppose, during treatment? What would be the best advice you would give?
Yeah. So I suppose it's like everything, you know, that the patient stays well and healthy. I'm not sending them on a diet. I'm not asking them to be in training for a marathon, but just, you know, just eat well. You know, you don't have to go on any special diets. Just have your normal 3 meals a day, plenty of fluids, go out for a walk. Maybe you're someone that doesn't go for a walk. Make that effort. Maybe you might only walk for 15 minutes the first day, but maybe by the end of the week, you've upped it to 30. And I just think overall it'll just help with everything. And it also takes the focus off having, you know, you don't want to be thinking about having this tumor all you're going through. It just kind of gives you just a little bit of
Mm,
normality.
mm,
I suppose then, like, we do have people, and everyone is so different, that would struggle. So like again, we use all our resources that we have here, engage in the different disciplines. I suppose if somebody was struggling from a psychological point of view, we would engage with Cancer Care West here, and we have a very good relationship with them, and they would see the patient as well. I
mm.
suppose sometimes, like, people are just afraid to ask for help because they feel they're failing where they're not. It's
Yeah,
it's it's
yeah,
part, you know, you have to very much
yeah. It's a
acknowledge, because I just
shame.
say to
It's a
people,
shame.
like,
I
whatever's
mean,
going on.
as you said
Yeah,
before, like this, bowel cancer isn't really, it's not a pleasant state of affairs at all. And so
yeah,
shame, I think, can
exactly. Yeah,
easily creep
yeah,
into the frame. And that's something we need to
yeah,
really tell people. Please do not be experiencing shame on the basis of, there's enough on your plate.
yeah,
Try to,
exactly. Yeah.
get through this. Shame has no rightful place in any of this, really.
Yeah, exactly. Yeah. And I suppose, like, people focus on the physical stuff that's going on, all that's going on, you know, whether they've had a stoma formed maybe prior to surgery, all these different things. The bowel, on account of having treatment, the bowel could be a bit more active. But then I just say to people, like, you have to mind your mental health as well as your physical health, because this
Yeah.
is very important, what goes on and how you're coping with things. I suppose then just in general, like your healthy living, what I mean, if somebody was a smoker, we would encourage them to stop smoking. We would use smoking cessation here.
Okay.
Then like you're talking about coming into an operation. So the whole ethos has changed now in preparation for surgery, as in like the patient is nearly kind of psychologically in training for it. So like again, I talked about the walking, because that opens up your lung capacity, minimizes any post-op complications. And then also then the patient would be given a date for surgery, because usually you'd operate within certain timelines. So I think it's very key that when the patient goes home, they have a date, they have a focus. This is where we're going. This is our end date.
Yeah,
They
this is a
know they're
plan.
coming in.
Yeah.
Exactly. Yeah.
Plans
And
are usually very containing for people, aren't they? When they
yeah,
kind of know what's
exactly.
happening.
Exactly.
Yeah,
Yeah. And
yeah,
then I suppose like the you have then the practical side of things. People have never been in hospital before. What do I bring? You
yeah,
don't want somebody bringing a big suitcase with nothing in it that really is benefit. So it's like your sensible things, your sensible slipper, light dressing gown, all that kind of practical side of things. But at least then for the patient, it kind of gives them an idea. Or I would go through like day 1 post surgery, day 2 post surgery, what's expected of the patient. But then,
yeah, yeah.
it's just so they have an idea, and like the length of stay, that they'd know they're in for 7 to 10 days, or some surgeries
Olivia,
they're
what
here
would
for
be
anticipated.
what would be your sort of top tips post treatment? So post surgery, for instance, what would you have any specific recommendations? I know you put you on the
So
spot.
yeah, I suppose what happens here is they say they go home, and I phone them the following week just to
Okay,
check in with them to see
okay,
how they're doing.
yeah,
Because what I say to people is, you think you're great in hospital, but you don't realize all that's done for you until you actually go home. And then you're home and you haven't got the nurse and you haven't got the bell and you haven't got the doctors around about you. So it's a big learning curve. So what I would say to people is, I'm a big thing about trying to establish a normal pattern. Like people then would be very tired after surgery. So what I do say to people is, just be sensible, get up at a normal time in the morning. If you do feel tired, just have a little rest maybe in the afternoon and get up again then, but could kind of go back to bed in a normal time, so that, what I
mm,
mean, you're not in bed for the majority of the day. Then you're not able to sleep at night, because rest is very important to the body. And then
mhm,
like practical things, like I'd say to people sometimes, you might be great the first day, go home. The second day, then you could totally dip down, and that's very normal. It's not that anything has gone wrong. You'll pick yourself back up the following day, and just
yeah,
kind of take it easy. You know what I mean? Just
yeah,
your body will kind of tell you what you're able to do, and just be sensible.
mm,
You don't have
mm.
to do everything, because it
I
takes
just
like
and
about 6 weeks. Yeah.
just on that note, actually, as well, we have Emma Houlihan at Cancer Care West in Galway. She's a specialist physiotherapist, and I think a lot of we have Emma and I have mutual patients, and we do talk
Yes.
about pacing, and the
Yeah.
correct kinds of attitude
Yeah.
towards doing enough, but not doing too much that is actually going to
Exactly. Yeah.
sort of lay you low for days on end. And, what,
Yeah.
and
Yeah.
we both have observed that actually when people are in that position, they get despondent. They think, well, what's the point? Or, I just can't keep going. But the thing
Yeah.
is, pacing is a really kind of good is a is a
And
is a good idea.
yeah. And I suppose for me, like when I do meet the patient, like I would meet, say, their next of kin, whoever that is. So I'd know the family dynamics then. I'd know when this person goes home, kind of what's ahead of them, and
Mm,
to accept the help. If help is offered, accept it. Then
yeah,
I'd say, like, also just practical things, like everyone thinks you have to come and visit you when you come home from hospital. You don't need anyone. You just need your immediate family, because, rest is very important. And I
rest
suppose it's
is
an Irish thing.
rest
We
rest is
feel
is
we
up
have
there
to,
with medicine, isn't
yeah,
it? It's almost on par with
yeah,
medicine.
yeah.
Yeah.
Yeah,
The
yeah.
old word was
That's just,
convalescence, wasn't it?
yeah, yeah. So I suppose just kind of like, and then I suppose for the patients then, like regardless of whether they had their surgery 6 months, a year ago, they can still ring me. There's no cutoff. They can ring me at any time. I suppose, like we do have standardized, we see them at 6 weeks post surgery, maybe 3 months and 6 months. But then if there's ever something that just isn't right, we can see them in a clinic. And that kind of gives the patients reassurance then that
Yeah.
that the
You're not on
door is
your own.
always open. It's not,
Yeah,
yeah. Or
you're not on
sometimes
your
it's
own.
maybe just we can talk about it over the phone, and it's something we can sort out over the phone. You know, a
Yeah.
lot of it can be that they don't have to rush to the GP straight away.
Mm.
So,
We're coming up to bang on 15 minutes. I said we
okay,
wouldn't kind of go
that's
after
fine.
that.
I suppose I'm a long time doing this job, so it's very, and I like it. So that
is there
makes.
anything that is, before we sort of conclude, is there anything that you would want to say, or anything that I've left out
Yeah,
to
I
ask about?
suppose just for patients that, you know, as we've discussed, like bowel cancer is not one of the popular cancers. Nobody really talks about going to the bathroom, what their poo looked like, whether there was any blood. You know, some people
Yeah.
don't even tell their husband, their wife, you know, and they go on with this like other realm in the bathroom. So I suppose just that people know what's the change, you know, what would be an indication that something isn't right. So like, has there been a change in your bowel habit? You know, have you noticed that there's constipation a lot more, diarrhea a lot more? Have you lost a lot of weight, kind of unexplained weight loss? Have you reduced your appetite? And if you've got a feeling of tenesmus, now tenesmus refers to when you go to the bathroom when you've had a bowel motion that you fully haven't emptied your back passage, that you feel you could sit back on the toilet again. And then if you're passing blood, any blood. So what do I do if this happens to me? You would contact your GP, and you would need to be assessed by your GP. I suppose then from there, then they'll either send a letter directly into our service, and usually the letters come to myself, so I would know about you from the day you've been at your GP, or sometimes then you're referred directly for a scope, which is a
And
colonoscopy.
if you're not happy with the
Yeah,
opinion of the GP, press
yeah. So then what I'd
click it.
say to somebody is, you know your body better than anyone. If something isn't right, it's not right, and be persistent and make sure you get it investigated. That, I suppose, is the biggest thing. We all know our own bodies. We all know if it's not right, it's not right. That's the kind of the bottom line.
That's the bottom line.
So
Literally,
yeah,
pardon the pun, but that's the
yeah,
way it is, really.
exactly. Yeah,
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 yeah.
yeah. So
Okay. I think I'll maybe bring it to conclusion now, but I suppose
yeah,
from my personal point of view, I've worked with a range of clinical nurse specialists in my sort of career so far, and your role is utterly invaluable, I think, and key in terms of helping patients feel informed, contained, safe. You just it's a really fundamental role, and I really do encourage patients, if you know, make your clinical nurse specialist your new best friend, really,
yeah.
if you've got queries, because they can really sort of contain and reassure. So I think, Olivia, the work that you do, your colleagues you do, is just so key and so vital. So thank you for your service. Thank you for your time
Thank
here
you.
today. I certainly really appreciate it, and I hope that what we've talked about today has been is helpful to patients going forward. So thank you
Yeah.
very much indeed.
Thanks very much yourself. Thank you.
Okay. Okay.
Okay.